structure and function. So, so basically, this causes lack of perfusion of the important organs, weakening or stiffening of the heart muscle over time that leads to pump failure and insufficient delivery of blood around the body. So, heart failure in India, it's like a tsunami, and we can only see the tip of the iceberg. So basically 16% of the global population we have, 25% of the world's coronary artery disease, around 120 million hypertensives, and a large number of individuals with rheumatic heart disease. So basically we are one of the top leaders for cardiovascular morbidity and mortality in the world. So a bigger challenge in India, why? Because the mean age is less, and it's around 53 here compared to the 73 worldwide. Higher mortality, in hospital mortality, and higher post-discharge mortality as well. So to summarize, the patients in India and with heart failure are affected at a younger age, have a higher mortality both in and outside the hospital. So this is a newer approach to classification of heart failure, stage A, B, C, and D. What we see in stage A is basically high risk of developing heart failure. So the patients have high risk of developing heart failure. So we have to see patients with CAD, hypertension, diabetes, family history of cardiomyopathy. So we need to see all these things and see which patients are candidates of developing or going into an advanced stage, and improve the blood pressure, diabetes, the coronary artery disease, and monitor them. Stage B is asymptomatic heart failure, that is previous MI, having LV systolic dysfunction, asymptomatic valvular heart disease. Stage C is symptomatic heart failure, that is known structural heart disease, shortness of breath, fatigue, reduced exercise. And stage D is refractory heart failure, that is maximum symptoms at rest despite maximum medical therapy, and such patients cannot be safely discharged. So there's an acute and a chronic phase to it. Heart failure is a chronic progressive condition basically, and it has acute episodes in between. So it's a chronic disease with acute exacerbations. And so we need to treat both the chronic aspect as well as the acute. So this is a general progression of and decrease in quality of life with people who experience heart failure symptoms, and they have impaired functional capacity and quality of life. So you can see a plateau phase, then a dip, then comes back, and then a dip again. So it's like a waxing and waning episodes. And the moment the quality of life index starts decreasing towards the end of the disease progression, and the mortality increases. Mortality rates in heart failure are high even for patients complained with best available treatments, and almost 50% die within 5 years after diagnosis. When heart failure symptoms are stabilized by current treatments, it may seem that patients are doing very well, but the neurohormonal imbalances underlying the heart failure is still silently occurring and resulting in disease progressions. So this is a very important point to understand, that even if you see a stable patient with heart failure, he's actually not stable. Also, heart failure patients, even those who are considered asymptomatic, that's exactly what I told you, or a mildly asymptomatic class 2, they also are at a high risk of dying. So clinical trials with median follow-up of 3 years have shown that almost 34% patients of class 1 and class 2 heart failure have a mortality, compared to 42% with class 3 or class 4. So these are very important facts, and we need to keep these in mind while treating such patients. So basically, when I talk about heart failure, I'm talking about HFrEF, which is heart failure with reduced ejection fraction. And there's a term with heart failure with preserved ejection fraction. So so what happens? Basically, there's continuous deterioration of cardiac structure and function with progressive worsening of the disease, despite absence of clinically apparent signs and symptoms. So we are just seeing the tip of the iceberg. We see the clinical stability, patient is taking diuretics, antihypertensives, and looks stable to you, but the reality is down below, and there is underlying structural molecular abnormalities which drive the progression of the disease, and there's silent and life-threatening complications which occur. So the newer therapies need to hit this part. So just these are pillars of the heart failure treatment. Neotherapies are acting at the fibroblast level, the extracellular matrix level, preventing fibrosis, cardiomyocyte hypertrophy, and death of the heart muscle, and progressive, and also decreasing the progressive cardiac dysfunction. So cardiac stress, injury overload basically leads to all these structural and changes which decrease the life of the heart muscle and progressive cardiac dysfunction. So neotherapies are acting at the myofibroblast level and the cardiomyocyte level. So what are the intrinsic mechanism worsening of silent worsening of stable heart failure? The intrinsic mechanism are again at the molecular level. They are cardiomyocyte apoptosis, mitochondrial anomalies, wall stress, impaired intracellular calcium cycling, fibrosis, and cardiomyocyte hypertrophy. An interesting mechanism which we all know are reduced perfusion, increased myocardial oxygen demand or consumption, and secondary tissue injury. These are just risk scores which predict the mortality, and we take into account the latest one, which is the magic one, emphasis HF, and the shift. So these are just risk scores which help us to guide which people will have more prone for progression, more prone for complication of chronic heart failure. And these are 13 highly significant independent predictors of mortality. And they've made the different risk as 1, 2, 3, 4, and the highest risk, the lowest risk being 17, and the very high risk being more than 33. Similar, this is a emphasis HF risk score. So just I wanted to show these slides to you so that we know that we have risk scores to predict which patients are going to do well and not. Again, 0 to 4 is medium, low, 5 to 6 is medium, and greater than 7 is a high risk score. So what does the risk scores do? Like what I told you just now, enable us to identify patients of heart failure at varying mortality risk and help us to calibrate management to individual patient risk. So where are we until recently? So the current therapies like beta blockers shown in various trials, Copernicus trials, that they help, they improve, reduce mortality, decrease hospitalization, ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists in the Rails trial, both spironolactone and eplerenone, diuretics, digoxin improves contractility but not mortality benefit, and vasodilators. So these are the current medications which we are all using, which are helping us, but this is not enough. We are treating the tip of the iceberg with these medicines. So are these therapies enough? Do we need anything more? Yes, of course we need anything more, because patients will not do very well if we don't. Patients, they deserve better, and the sooner we act, better for our stable heart failure patients. So what do we have in store for us to offer them? So the stable one is sacubitril valsartan, known as Vimada in India and Entresto in the international community. And so this has come in and it has really modified the treatment of patients having stable heart failure, which is actually not stable, but having heart failure with minimum symptoms. And it has seen reduction in the lower risk score group as well as in the high risk score group. Both people benefit. So greater reduction of CV death was seen in patients with low risk. So this is the game changer which has come. And also reduction of hospitalizations. If you compare it to a ACE inhibitor, it was significant reduction of hospitalization with a p-value of 0.02. And both the groups. Why am I showing this? Is that both, you don't need it in the high risk class 3, class 4 group. Class 1 and class 2 also do very well with this. So what was the main trial which analyzed this was the Paradigm heart failure trial. So mild symptoms, so-called stable heart failure, but at risk, very large benefit in a short period. So you can see per 100 patients treated for 2 years, 3 fewer patients in lower risk group experiencing primary composite outcome in Vimada or Entresto, whichever one we call it, in this group. Similarly, if you take another risk score compared to this magic risk score emphasis, similar reductions you are seeing, both in the low risk as well as in the high risk patients. So two major modes of death are seen in the heart failure patients. In the mild heart failure, sudden cardiac death. This is very important to understand, and this should be our main focus. In severe heart failure, death may be due to sudden cardiac death as well as worsening of heart failure. So the importance of sacubitril valsartan combination is that it has influenced both mild as well as severe heart failure. It reduces sudden cardiac death and non-fatal clinical worsening in both the groups. So what do we think about this Vimada and function status of the patient? So we have seen Vimada minimizes function status, minimizes functional deterioration, and positively impacts the NYHA class of the patients. So you see, as the duration increases, the patients do better. Also, if we compare the quality of life indices, we see that Vimada significantly improves the quality of life index as well. So very important. So does it have greater benefits in stable heart failure patients? We can see why. Why? Because it decreases the progression of the ongoing deterioration in the cardiac myocytes at the cellular level. How it does that? It has neprilysin. Neprilysin decreases all these vasoactive peptides ANP, BNP into fragments. So if you inhibit neprilysin, you can see the enhancing effects of vasodilation, which is decreased blood pressure, decreased sympathetic tone, aldosterone levels, fibrosis, hypertrophy, and potentiates diuresis. And we already know the good effects of angiotensin type 1 angiotensin 2 type 1 receptor blockers are that they inhibit the increase in blood pressure and everything. So combining these two leads to decrease in progression and worsening of the heart failure mechanisms which are damaging the cardiac myocytes. This is exactly which I said in the previous slide. They act at the underlying structural and molecular abnormalities which drive disease progression, that is a silent and life threatening. So basically we need to stop the disease progression. So just a practical consideration for our audience is that whom to treat: ambulatory HFrEF patients, NYHA class 2 to 4, monitor the NT-proBNP levels, heart failure hospitalizations in last 12 months, prior treatment with AS and ARBs, systolic BP more than 95. I'll come to this later. Lower potassium levels, renal dysfunction should not be there, and no history of angioneurotic edema. So, and how to titrate? So there are two concepts in this: start with a higher dose and start with a lower dose, a conservative approach. I would, out of experience, say a conservative approach is much better. We start with a lower dose 2 weekly and then gradually increase by monitoring the systolic BP. And how to follow them up? Daily blood pressure monitoring for any signs of hypotension due to the initial treatment. Creatinine and potassium initially weekly, then 4 weekly, and then monthly. And then after that, every 4 months. If the patient has hypotension, decrease the dose to half for 2 weeks and then monitor again. Reassess the dose after every 2 weeks, and treatment and follow-up in specialized heart failure centers. So this is just a summary of what I said. One more important thing is that when the patient is taking ACE inhibitors, there has to be a washout period of 36 hours because sometimes it precipitates angioneurotic edema. And with ARBs, you can directly switch. And these are the two approaches which I just told you. This is from low dose and from high dose. I think a low dose approach is much more clinically much better and helps very low discontinuation therapy with a lower dose approach and then taking it higher rather than from a higher dose approach. So another medicine called dapagliflozin, which is a class of SGLT2 inhibitors in patients with HFrEF and HFpEF. So this is also have come as a new game changer in heart failure patients. How does this SGLT2 inhibitor help? basically because we are concentrating more with heart failure with reduced ejection fraction, we have seen that there is all modalities, repeated hospital heart failure admissions, cardiovascular death, and all cause mortality all decrease when the dapagliflozin is added. So how do the SGLT2 inhibition and cardiac protection take place? We've seen that improve ventricular loading conditions, that is diuresis, natriusis, afterload reduction, molecular energetics and metabolomics, direct effect on the myocardium, and also insulin-like growth factors and transforming growth factors reduction. So basically, it acts at all the levels you can see. So absolute game changer just now with SGLT2 inhibition. So why do these SGLT2 inhibitors reduce heart failure hospitalization? So basically a differential volume regulation. You can see that how they regulate the blood volume. There's a gradual volume reduction with decrease in spikes and decrease in the interstitial fluid volume. And how do they change the hemodynamics? You can see the 24-hour systolic blood pressure, daytime systolic blood pressure, nighttime systolic, and in-office all better controlled with the SGLT2 inhibitors. So what effect do they have on cardiac remodeling? So when it was assessed by echo from baseline to 6 months, so we could see that the left ventricular mass index as well as the mitral inflow pattern all became beneficial with this. So helping the patients, decreasing the progression of disease and relieving the patient of the symptoms. And so it's a DAPA HF trial, which was the one which really made SGLT2 inhibitors, dapagliflozin, very important with patients with heart failure with reduced ejection fraction, with or without diabetes. So the background, just I want to tell you that they prevent the development of heart failure in patients with type 2 diabetes. And can they be used to treat patients with established heart failure? Number one, is the benefits of SGLT2 inhibitors with maybe glucose dependent? Can SGLT2 inhibitors be used to treat patients without diabetes? So all this was tested, and both the groups, with and without diabetes, both benefited from SGLT2 inhibitors in patients with heart failure with reduced ejection fraction. So this was the primary composite outcome, very, very statistically significant. Cardiovascular death, heart failure hospitalization, heart failure visits all decreased with dapagliflozin. And worsening heart failure also decreased, and cardiovascular death also decreased. And this was in both the subgroups, with diabetes and without diabetes. That's a very important point. So SGLT2 inhibitors act with diabetes and without diabetes, both. Also, patients who are given SGLT2 inhibitors taking sacubitril/valsartan combination, still both of them did very well, whether they were taking it or not. So acts with it and without it also. So SGLT2 inhibitors have come up and they are really adding to our armamentarium in managing heart failure. So now patient is on maximum medical therapy, and now we need to see still symptomatic. So we need to see which patients are candidates for device therapies in heart failure. So since we've already discussed that sudden cardiac death is an important aspect in heart failure seen in patients with heart LV dysfunction, and various trials have shown that sudden death is there, and as the duration increases, the mortality and sudden death can increase, and it is different in different class of heart failure patients. What are the factors involved or related to sudden cardiac death? QRS duration, very, very important. QRS duration, independent predictor of mortality. Other factors are age, heart rate, ejection fraction, renal dysfunction, all adding to causes of sudden death in patients with heart failure. So this is just a, diagram showing you how ventricular remodeling leads to cardiac dilatation in patients having heart failure. And this is just to show with heart, when there is a hypertrophied heart, that is a heart failure with preserved ejection fraction, you can see hypertrophy and then later diastolic heart failure, and leading to dilated heart and then systolic heart failure. So problems with drug therapy may not increase ejection fraction, though the addition of newer therapies have seen increase in ejection fraction, but it may not increase. Side effects may lead to discontinuation of therapy. Adherence to therapy is a big problem, and worsening heart failure, requiring frequent OPD visits and hospitalizations, may require recurrent admissions with inotropic support and various therapies. So these are the problems with drug therapy. So cardiac resynchronization therapy. So what is the proportion of mortality? We see as the QRS duration increases, the survival decreases. So what are the associated problems with wider QRS? There is a prolonged AV conduction delay, which causes suboptimal atrial systole, limited filling period, and increases mitral regurgitation. Also, delayed ventricular activation, what does it do? It delays the lateral wall contraction and disorganized ventricular contractions, decreases the diastolic filling time, and prolongs MR and decreases the pumping efficiency. So with a wider QRS, all these problems come up. This is just a diagrammatic seeing what type of dyssynchronies happen. We can have a atrioventricular dyssynchrony, an intraventricular dyssynchrony, and an interventricular dyssynchrony, all leading to cardiac dilatation and decrease in contraction. So these are the therapy stimulation therapy sites, and close to the sinus node and the RV and the lateral wall, which we go through the coronary sinus. So these improve the coordination and improve the pumping efficiency of the heart. So these are devices. You have an atrial lead, a right ventricular lead, and one lead in the coronary sinus. You have many leads, a quadripolar lead, a bipolar lead, and a lead with now advanced lead with multi-site pacing. I don't want to go into the details of that. So just a echo guidance that you see that before CRT, the diastolic filling time is less, and then you can see the cardiac muscle relaxes and the diastolic filling time increases and patients improve. These are just to see that how the cardiac size decreases with baseline and then post therapy. So on top of optimal pharmacological, this is all on top of optimal pharmacological therapy, which I am telling you, that we can see that how add-on therapies and combination therapies ultimately, and adding a CRT decreases the mortality in patients with advanced heart failure or heart failure which progresses. So just to summarize the general guideline, NYHA, this has now changed. It's also involving two, which I'll just show you later. Reduce ejection fraction. There is LVD dilatation on echo. If the QRS is more than 120, then the patient is a candidate for CRT. And there is a therapy called CRT-D. D means defibrillation. One of the leads has a defibrillator with it. When are we putting this? We are putting this if the patient overall reasonable life expectancy is more than 1 year. Then you need to add a CRT-D with it. I will just come to that. So these are a few landscape trials which impose how CRT is helpful even in mild heart failure. So reverse, MADIT, RAFT, all showing that how it helps in mild heart failure. So now just to see that, look at the sudden death column. So almost 64%, 59%, and 56%. It's 33%, sorry. So it is so much more common in class 2 heart failure. So to prevent sudden death, we are, and the guidelines have been revised, and so, and 2, 3, 4 have been added. Ejection fraction less than 35%, QRS more than 150. You have to go in for a CRT, and a CRT-D indicated if life expectancy is greater than 1 year. So basically a CRT-D is for younger people. When I was in Europe, I was in Germany, I was seeing that patients of more than 80 with left bundle branch block and heart failure symptoms, they were giving CRT, and patients with less than 80 years with more chance of long-term survival, they were giving a CRT-D. There was just the hospital guidelines, that particular hospital. But what the major thing is that CRT-D is very important because there is a lot of incidence of sudden cardiac death in patients with mild to moderate symptoms. Implantable defibrillators, this is what I was telling you. So you can do it, add it along with CRT, which makes it CRT-D, or there are indications of improving survival if you just put a defibrillator in ICD. So again, sudden cardiac death, you can see how much it is, this is what we have to target basically. And you can see how it decreases with a plain defibrillator, ICD, implantable cardioverter defibrillator, compared to the conventional therapy. So there were two trials, MADIT2 and SCD heart failure trial, all showed that even a single lead shock device, that is ICD, decreases the mortality by 23%. So what are the indications? Just to summarize them: heart failure for 3 months, for at least 3 months, ejection fraction less than 35, NYHA class 2, class 3, greater than 1 year of life expectancy, ischemic or not, both help, more in ischemic but also non-ischemic. For a plain ICD therapy, no QRS duration is required. So we have discussed about newer therapies, how to, which patients to give what are the basic things we need to look after. Just to, before I finish my talk, I wanted to discuss this because this is very important in optimizing the heart failure therapy, is how do we titrate these medications, or what are the major barriers to medication titration. We know there are well-determined treatment by guidelines and innumerable situations which may limit the guideline-directed medical therapy. Why? Because some patients may not tolerate medications or recommended doses, or may have side effects. In some cases, there is excess of caution. We are worried about the side effects, failing to prescribe the recommended dose, giving a lower dose, fearing complications. So we need to overcome this. So the most common feature in all these medications is hypotension. Very important. The moment we start any heart failure medication, patient comes to us with a BP of 96/60, and then we stop the dose, we decrease the dose, we make it half, and this is how we don't give the patients the optimal benefit of that therapy. So this is the most important barrier among all, hypotension. It's like the ghost of heart failure therapy. So why does hypotension happen? Basically, patients with heart failure activated neurohormonal response, vasoconstrictions, a little higher BP. The moment we treat them with the guideline-directed medical therapy, the BP comes down. But the data in the literature suggests that the lower BP is actually a marker of effective treatment. So we should not worry much about it. It's a marker of effective treatment. The main limiting factor is the treatment of heart failure is not hypotension, but we are not understanding the concept of hypertension. The diagnosis of hypertension cannot be relied only on absolute BP. Adequately medicated heart failure patients usually have a low BP, around 90, with no symptoms. So symptoms are important. If the patient is not showing any symptoms of hypoperfusion, I think a BP of 90/60 should not be taken as a complication or as a thing to stop the therapy. So in case you have a symptomatic hypertension patient, so what is the order of changing the therapy? So if you have which medication you should discontinue first. So in case of no objective signs of congestion, we discontinue diuretics because hypotension is most often due to the diuretics. Then reduce the dose or stop nitrates or hydralazine combination. And RAST are the last block, like so ARBs and ACE inhibitors or sacubitril valsartan, they are all last in the list to be stopped because they have the maximum benefit. So this is the order we should change. And in the paradigm HF, it was seen that lowest systolic BP category attained the same relative magnitude of benefit. So they were the sickest patients, but they attained the same level of benefit with compared to the overall patients. So we should not worry about a BP of 90/60 or 96/60 unless the patient is showing signs and symptoms of hypoperfusion. So you can see the patients with low BP also had 12% reduction in cardiovascular deaths or heart failure hospitalizations. Also, 15% reduction in all-cause mortality. So, lower BP, not to worry, see for signs and symptoms, and then taper the medicines which you think can cause lower BP. Also, how to optimize therapy. I've told this to you before, gradual up titration, which will lead to more continuation and less discontinuations. So just to summarize all what I've discussed, hypotensions need not act as a barrier to optimal treatment of heart failure. Sacubitril/valsartan improves clinical outcomes in heart failure with reduced ejection fraction in patients with low systolic BP and does not increase discontinuation rate due to symptomatic hypotension. In stable heart failure patients, the underlying structural and molecular abnormalities drive disease progression, which remains silent and undetected and untreated, leading to life-threatening complications. Sacubitril/valsartan has a potential to correct some of them. The ideal therapy for heart failure patients is one that reverses or prevents the progression of intrinsic cardiac structural and functional abnormalities, improves skeletal muscle function, affords necessary protection to the kidneys. Dapagliflozin reduces the risk of worsening heart failure and cardiovascular deaths and improves symptoms in patients with heart failure with reduced ejection fraction when added to standard therapy. Relative and absolute risk reductions in death and hospitalizations were substantial, clinically important, and consistent with across all subgroups. Well tolerated and rate of treatment discontinuation was low. Dapagliflozin offers a new approach to treatment of patients with heart failure. So you should keep your chin up and your BP blood pressure low. So this is our motto: chin up and low blood pressure. Thank you.
Thank you, Dr. Omar. And I think it is a nice presentation and very informative. Some of the questions have already been raised. We'll discuss now one by one. The first question was presented, that was prevention of heart failure, especially in diabetes mellitus.
Yes.
So prevention of heart failure means prevention of creation of substrate for heart failure. That means those who have no structural heart disease yet, you have to prevent that. That means prevention of ACS, prevention of NMI or damage to myocardium will be the primary aim to prevent heart failure. And also, particularly in diabetes where there is a chance of heart failure with reduced ejection fraction, chance of heart failure with moderately reduced ejection fraction, or heart failure with normal ejection fraction. All substrate as possible in diabetic patients. You have aptly described regarding SGLT2 inhibitor use in diabetic patients. They are very much cardiac friendly. Those who have not yet developed any signs of heart failure, that means still in the stage A or stage B.
Stage A, yes.
Prevent that, particularly in patients who have diabetes or non-diabetic with obesity and other cardiac risk factors. So any comment, anything you want to add regarding this prevention of heart failure in diabetes mellitus?
I think you've just summarized it very beautifully, that stage A or stage B, that is either stage A or stage B. So good diabetes control, managing of CAD in such patients will lead to decrease in further progression of the disease. Absolutely.
Our idea will be to prevent cell loss, to prevent structural abnormality in patients with risk factor of having heart disease. Next question has been put, that is any benefit of adding ivabradine over beta blocker?
If ivabradine with on top of beta blocker.
That means patient is on regular therapy, he is on a inhibitor, beta blocker, maybe on RNA plus beta blocker. If the heart rate is still more than 75, can we add ivabradine? And that is relevant or not? That is
absolutely. That's a very nice question. In fact, ivabradine is an important game changer and helpful in our medical management of heart failure. So you have a beta blocker, you want to decrease the heart rate to around 60 to 70. And at the heart rate of 75, 76, you're seeing the BP has become borderline. So very important at that point to add a add ivabradine, and which will again bring the heart rate down to around 60 to 70, which is the ideal heart rate in which we have seen the patients do well.
That means it can be used unless it is contraindicated, and data behind it are SIFT trial, that is one part sub study that shows it can be used.
Yes.
Beautiful study was mostly targeted to this beautiful trial, and signify that is use of ivabradine if the patient is contraindicated for beta blocker but not yet developed any overt heart failure. That means if we combine the knowledge of these three trials, SIFT, beautiful, and signify, then we can use ivabradine with or without beta blocker. That means beta blocker is our first choice because they have got another effect, that is anti-apoptotic effect. That means cell loss will be reduced. Ivabradine can reduce cell loss by modifying strain only. Not that direct cellular effect is there. It can reduce the heart rate. Myocardial wall rate will be well distributed. Myocardial wall rate will be less. So cell loss will be less. Subendocardial cell loss will be less. So your answer to this question will be yes, and there are clinical data which support our concept.
Thank you.
Next question has been put forward. Any trial, I am going from back, any trial of CRT device and SGLT2 inhibitor combined use?
Question kora jabe.
Yes.
I think all the trials have optimal medical therapy and then you add a CRT to it.
Yes. Regarding this is a newer drug, that is RNA SGLT2 inhibitor and CRT.
Yes.
Two trial, that means DAPA heart failure has got a sub study that shows some of the patients were on CRT, they were having maybe mild responder or non-responder to CRT. It has been shown that introduction of RNA improved their symptom.
Yes.
So that is also a sub-analysis, but that is favorable. That means DAPA heart failure sub-analysis shows that if we add RNA, particularly empagliflozin, that or dapagliflozin to patient already on CRT, they will improve.
Yes, they will.
And direct trial related to empagliflozin, that is emperor reduced trial. That means emperor reduced trial. That is a sub-study of emperor trial.
Yes.
That also shows that we can use the SGLT2 inhibitor on patient with CRT. Their response will be more favorable.
Yes.
Those who are already responded, their functional class is improving. Their working capacity is improving. Their other inflammatory marker are going down. So from that point, this trial also favors use of SGLT2 inhibitor in patients with CRT.
Absolutely.
Since it is a combined use is highly favorable.
Medical therapy has to be optimized, and these are add-on therapies.
Regarding SGLT2 inhibitor and RNA combined use, any caution in patient with CKD? That means if the patient is having CKD, we are going to give SGLT2 inhibitor and RNA both.
So there is more chance of renal dysfunction in such patients.
That means monitoring of renal parameter to be assessed very frequently.
Very frequently.
Can be used. First of all, we have to assess the patient whether they are very compliant or not. If they go back and come up as 3 months or 2 months, those patients are not favorable for this kind of therapy, because already CKD, we are going to introduce 2 drugs, both having chance of renal deterioration.
Yes.
So I think their compliance should be assessed fast, and then we can introduce this group of drugs with favorable result.
Also with dapagliflozin, we need to monitor the blood glucose level also.
Yes.
Yes.
And also they cause interstitial drying. That means interstitial fluid will be drained out more.
Yes.
Chance of tissue concentration of RNA will be more. And intraglomerular, that means medullary concentration of SGLT2, that means RNA will be more. That means renal concentration, blood concentration will be different. That means those who have interstitial dryness, their chance of tissue level, interstitial level of RNA will be much higher.
Is there a dose reduction that is required?
Which one?
Is there a dose reduction required?
Yes, dose reduction is definitely required, and introduction of therapy will be with 25% of the dose or 30% of the dose. Never more than 50%. It can create an AKI kind of thing, may land up with dialysis also. That's why ARNI with SGLT2 inhibitor needs a special caution, because SGLT2 inhibitor will cause interstitial tissue dryness. That
Yes.
interstitial tissue concentration of ARNI will be much, much higher. That means what ARNI in doing in a euvolemic patient or ARNI doing in a patient who have interstitial dryness is totally different. That's why use of these two in a patient already having some renal dysfunction needs special caution to avoid this kind of bad effects.
We need to calculate the GFR before we start both the therapies together.
That to be calculated, that to be monitored weekly, if
Yeah.
required bi-weekly. And incidence of hypoglycemia with SGLT2 inhibitor in non-DM patients, that was another question.
Yes.
Dr. Omar, highlight this area, incidence of hypoglycemia with SGLT2 inhibitors in non-DM patients.
Yes, there is incidence, but the discontinuation because of this was not much. So there is incidence of hypoglycemia in non-diabetic, but discontinuation of therapy was not much.
Another question has been given. Evaporatin already we have discussed, and another question has been given, that is by Icrcpi Banerjee. Have seen cardiologists use Bhymeda after angio with ejection fraction of 50%. I think ejection fraction of 50%, this kind of patients benefits more or same or less, Dr. Omar? Patient having ejection fraction of 50%.
So this is basically heart failure with preserved ejection fraction.
Yes.
So also patients with heart failure with preserved ejection fractions, that was seen that Vimada also modifies the cardiac damage and the cardiac myocyte fibrosis and helps future outcomes, which later on they lead to ventricular dilatation and heart failure. So it also helps in that subgroup. That is also coming out.
That means it is like a drug where rheumatologist says that disease modifying agent.
Absolutely. Perfect.
So it will be like a disease modifying agent in heart failure.
Yes. Yes.
Ejection fraction of 50 or 55, they are also candidate for this kind of therapy, and we can term it disease modifying agent in heart failure.
Absolutely.
Hello, this is Dr. Sinha here. Can I ask one question, please?
Yes, sir.
Now, the speaker said that Indian heart failure patient, you get more mortality than the other counter-Western part. May I know what is the reason? A. The second thing, in spite of using this modern treatment for heart failure with the RNA and other existing the recent SGL2, can we prevent the patient in this group from going to the treatment with ventricular device treatment?
Dr. Omar, highlight this area.
Yes. So basically, why more mortality in Indians is because we are seeing CAD is the most common cause of heart failure. So more of CAD in our country, more diabetes, more CAD, more heart failure, so higher mortality. Number two, we are not identifying.
Is there any genetic factor?
Yes, sir. Asian genetics has got a bad implication. And even in teenagers, we are seeing diabetic dyslipidemia, even in non-diabetic young teenagers. That means low HDL, that is the major culprit, high triglyceride, and normal cholesterol or normal LDL, but oxidized part of LDL is very high. That biochemical abnormality create a internal milieu that favors to have acute coronary event more. That's why myocardial cell loss, God-given cell is getting lost. Once it is lost, he is a patient for chronicity. That is that is happening in young age. That's why there is more incidence of heart failure in Asians, and their response to treatment is also bad because adherence to therapy is also very poor. Compliance to non-drug therapy is also poor. Family support is poor, and also their continuation for further therapy usually they deny. These are some of the additive factor. Along with that, once there is a good amount of cell loss from the heart muscles, we cannot recover that. What we are doing after a cell laws that is all supportive. Not that cells are there, we are making them active. It is there was a question when to consider for cardiac transplant. If the heart failure is refractory, cell loss is too much, assist devices are still not working, they are just acting as a bridge, then we have to think of cardiac transplant also. There is a question by Ashish Bhattacharya. Sir, when to consider IBP, when to consider cardiac transplant in DCM? That means when all therapies are failed, other organs are favorable, we can consider for cardiac transplant in DCM. And consider for IBP, this is actually a emergency treatment when there is a severe cardiogenic shock not responding to any other therapy. We use IBP or ventricular assist devices just to bridge for transplant. Because in DCM, IBP will not change your prognosis either in hospital or out of hospital or long term. It is just a bridge to transplant, nothing else.
So basically, these assist device therapies are actually bridge. Like we have the newer device, which is called an Impella, which is also a left ventricular assist device put transfemorally. So all these are like bridge devices helping you to remove a cause which is causing heart failure, but not helpful for very chronic heart failures which are not responding. And even Dr. Amal, you said about CRT and which candidates. Basically, we need to see the QRS duration. So not all heart failures have a wide QRS duration. So they are not candidates for CRT. So we have to give drug therapy to them. And only when the drug therapy is not working, then they become candidates for CRT. There are lots of patients, and I think Dr. Prakash must have seen that patients coming to us with ejection fraction of 25-30% with LBB, and we add sacubitril valsartan to them and monitor them, and after 3-4 months we see that the ejection fraction is up to 40%. So we don't immediately take them for a CRT. We give them optimal medical therapy and then only decide about the CRT.
Okay. I must interrupt over here, Dr. Prakash Mandal and Dr. Omar. It's been an excellent discussion, and think it will go on. I think in the interest of time, we have to close this session. So thank you very much, both of you. There are some questions in the chat box and in the Q&A. So after this session, can you please answer those, and the persons you've asked it can get their queries. Thank you very much. Thank you. Excellent.
Thank you. Thank you.
So, Debashish, thank you very much. Can we move to the next session, please? Debashish, can you give me the... Okay. So the next session is very, very interesting. We have on infectious diseases, is on post-exposure prophylaxis for HIV, HBV, HCV following needle stick injury. And we have very senior chairperson, Dr. Amal Kumar Sinha. He's one of the senior most in the RCPI family. And we have a very, very experienced and international figure in infectious disease, Dr. Bharat Bhushan Rewari. So over to Dr. Amal Kumar Sinha. Dr. Sinha, I'm sure you know, he's an examiner for the MRCPI, and he's a very senior consultant physician at MRI Hospital, Dakuria, Kolkata. So over to you, Dr. Amal Sinha, please.
Thank you very much, Mojit, for introducing me. And it is a great pleasure for me to chair an important area in clinical practice, actually rather day-to practice, the needle stick injury and its prophylaxis. We all know needle stick injury leads to an exposure that might place the healthcare personnel or the workers at risk of acquiring bloodborne infections, and these infections may be bacteria, protozoa, virus, fungus. Among these, most important is the virus, because see, important viruses needs mentioning because of associated increased mortality and morbidity in clinical practice and the hospital practice also. These are human immune deficiency virus, hepatitis B virus, and C virus. And it is estimated about 400,000 needle stick injury occur in the hospital population. Having said that, surprisingly, most of them are not reported. So the primary prevention is the most important strategy to avoid these bloodborne infection in hospital workers. When an exposure do occur, there is secondary infection, and that should be exposure-specific prophylaxis for the hospital employees and the health workers. Now, to highlight and address these topics, we got a very renowned person, Dr. Bharat Bhushan Tiwari. He has got vast experience in this subject, and he's expert on his speech and discussion. So I will request him to talk on this one. Before I ask requesting him, I just want to say a few words about him. He has got many international national papers, supervised the role and scale of ART program in India, over 10 lakh patients as program officer at NACO. That is very important in this talk. Fogarty Fellowship on HIV, John Hopkins University at Baltimore, USA, member of WHO ART Guidelines Committee 210 and 213, member of HIV TB Core Group as top department WHO headquarters Geneva. He has got, I told you, he has got 90 publications internationally and co-editor of book HIV/AIDS Clinical Perspective, first chairman of API Delhi chapter, first president of Indian Association of Clinical Medicine, and past vice president API National Government Body. Dr. Tiwari, please, over to you. Thank you very much.
Dr. Tiwari, need to share your slides, please.
Yeah. Good morning. Thank you for giving me this opportunity and also a nice introduction by the chairperson. Thank you very much. Can you see my slides now?
Yes.
Okay. So thank you for this opportunity for talk on post-exposure prophylaxis for HIV, hepatitis B and hepatitis C following a needle stick injury. Let us see this scenario. We have a 45-year-old truck driver coming to casualty department. He has got headache, fever, vomiting for last 4 to 5 days, disoriented with his surroundings, and he has mild neck rigidity. He had some history, vague history, that he took some treatment which was for 5 to 6 months, could be tuberculosis 6 months. And then while doing a lumbar puncture, there is a needle stick injury and there is a blood visible on the finger. We also see, and this is a real life scenario, nurse is putting up a venflon, gets an emergency call, leaves the stellate on bed, comes back, puts in a drip and stellate puncture the side of forearm, which is very common practice in public health hospitals when you have number of patients. Lab technician drawing blood, child moves due to pain, needle pricks him. Similar thing, what should one do in such situation? Another situation not related to needle stick injury, but 25-year-old girl going alone at night on the ridge area. This was very bad incident few years back, assaulted by few persons, brought to casualty. Assaults were basically under influence of alcohol. What should be the protocol? Not needle stick injury, but a similar situation when there is a exposure. We know that needle pricks are a big danger to doctors, nurses, laboratory technician. Just a momentary lapse can lead to a needle stick injury. And in initial part of my career, not now, I've seen that fear of acquiring HIV has been reason for denial of treatment. No longer a big problem now. Now people are taking care of PLHIV across the country. Surgeries are being performed, but still we see occasionally children being moved out of school, some patient not being adequately attended to because of fear of HIV. What should be done? A needle stick injury can happen despite taking all precautions. Even with universal precaution, needle stick injury can happen. What should be done immediately?
Sir, there is some problem with your voice.
You're not able to listen me clearly?
No, sir, sometimes it's going down. I don't know whether it is the same problem everybody is facing.
I'll put up my headphones.
Now we can. Carry on, please carry on.
Yes.
Better? Okay, thank you. So what should be further course of action if a needle stick injury has happened? And our aim is to prevent not only HIV but other also bloodborne infection, and as the chairperson highlighted, the viral infections in particular. So immediate step basically is immediately wash the wound. Wash the wound surrounding skin with water and soap, nothing else. Do not use any antiseptic, do not use corrosive, do not use other corrosive which will attract more of the phagocytes and cytokine receptors to the site. Do not use bleach, chlorine, just wash with skin, soap and water. Do not scrub, do not rub. Exposure is to eye, irrigate eyes with water or normal saline. If it has gone to mouth, spit out the fluid immediately. Rinse the water thoroughly using water and saline. Do not use soap or disinfectant in mouth. What is not to be done? Do not panic, because when you panic, you must have seen that immediately you see blood on your finger and you put your finger into the mouth. That is a very old reflex. Again, do not use bleach, chlorine, alcohol on the wound. Immediately, person should be evaluated for severity of exposure and started on post-exposure prophylaxis within 2 hours, which is a challenge to get the drugs, get the evaluation within 2 hours. So we'll see how can we start PEP within 2 hours. But again, before I go to post-exposure prophylaxis, we should remember this is the second best approach to preventing occupational exposure to HIV, first still being the prevention. So let us focus a little bit on the prevention. Needle stick injuries can lead to serious or fatal infections. More than 20 pathogens have been reported. Most common one are hepatitis B and C virus and HIV. And this can not only lead to bloodborne infection, but could have severe emotional impact on healthcare personnel, even if it turns out to be negative later on. Approximately, there are 8 million health workers in US. We have no data from India. There are 600,000 to 800,000 needle stick injuries. Again, data is 30 needle stick injuries per 100 beds per year are seen in US. The most common cause of needle stick injury is a hypodermic needle, which is accounting for 28% of the total injuries, followed by suture needles, followed by the winged steel needles, glasses, and other hollow bore needles, phlebotomy needles, and other type of injuries. All these are clubbed, even when it happens from a glass vial, broken glass syringe, they are all constituting needle stick injury. Does not mean only from a needle. The person who are at maximum risk are nursing staff and laboratories, people in emergency care, interns and medical students, because senior people are usually not involved in the actual emergency care, except of course in some critical procedures. But so it is laboratory person, nursing staff, labor room staff who are more at risk of getting HIV exposure. So when we say post-exposure prophylaxis, the talk is basically following needle stick injury, but it is not only for healthcare personnel, it is also for relations looking after HIV patients. Sometimes HIV patients, there can be exposure to them, the mucosal exposure can be there. Victims of sexual assault. I mentioned the scenario 3, they are victims of sexual assault who also require post-exposure prophylaxis. And of course, unprotected casual sex, we can also prevent HIV through post-exposure prophylaxis. But there are other issues related to that, that whether they should be regularly taking PEP if they have regular unprotected sexual casual sex. Okay, I think we have done this. Let us see what is the relative risk of seroconversion. HIV transmission after percutaneous exposure happens, chances are 0.3%. 1 in 300 exposures can lead to an HIV acquisition, while for mucous membrane, it is 1 in 1,000. But when I say 1 in 300 or 1 in 1,000, we don't know. This could be first also. It could be first exposure, second exposure, and 1,000th exposure. But just to compare with hepatitis B, the chances are 6 to 50% of an needle stick injury, and hepatitis C is 1.8%. So you see, hepatitis B also remains a major problem. And when we talk of post-exposure prophylaxis, hepatitis B often does not get that attention. People are more concerned about HIV rather than hepatitis B. Though the chances are significantly higher for hepatitis B, particularly when the source is surface antigen positive and core antigen positive, the chances becomes very high. These are, what I showed is basically the chances, but these chances increase, the risk of transmission increases if the volume of blood is more, There is a visible blood on the device. Procedures which involve placing a needle in the patient's vein. A deep injury, person had a recent seroconversion, or it is an advanced case of AIDS, the chances of transmission will be more than 0.3% or more than 1.1%. Environmental transmission does not happen. There is no case of environmental transmission because HIV is inactivated quickly outside the body. It has to multiply in the CD4 cell, cannot multiply outside the body, and infectivity is lost quickly after the fluid dries up. But still, again, little emphasis on universal work precaution. The basic principle have been developed over the years, but many a times we see that these basic principles are not followed, particularly by residents. When I say maybe because of the large number of patients, could be non-availability of the universal or precaution material. I've seen hospitals during my travel from NACO, hospitals in some of the states didn't even have soap and water freely available in the emergency. So we have to see those challenges. Uh, Patient hands should be, the person should wash their hands after every patient contact. They should plan for safe handling of disposal of the, particularly the sharps, use needles, and wear glove when contamination is anticipated. Protective eyewear and mask should be worn when splashing is anticipated, particularly in the labor rooms. All waste soiled with blood and body substances should be disposed of according to relevant standards. So this is important because it is not only healthcare personnel, it is basically people who are disposing the garbage, who are waste management. They are also exposed to needle stick injuries, and they will not even know from the source from where the injury has occurred. It could be just a disposable bag and that they get a garbage bag and they get a needle stick injury. Also, double gloving does not help. Basically, double gloving is not supposed to be providing any, rather it becomes more clumsy. So what are the body fluids which are infectious for HIV? Blood, plasma, sexual fluids, breast milk, blood tinged fluids are one which are at the highest risk of basically getting HIV. All other body fluids like CSF, peritoneal, pleural, pericardial fluid have moderate chances, but saliva, vomitus, sweat, urine, feces, there is no chance of basically getting infectious from them unless they are contaminated with the blood. So what are some of the universal precautions? We have been saying no recapping of the needles, no bending of the needles. Needles should be disposed of in puncture resistant containers, which looks big, but a simple bread box with little bleach in that is enough to dispose of the needles. Needle shredders are available for as low as 100 rupees, which are mechanically operated. Person should take care that they don't leave needles on the bed. They don't pass sharp by hand, which is a practice in the operation theaters. Rather, they should be provided in a kidney tray. Use protective gear at all situations. Say no to mouth pipetting. Pipetting should be automatic. Consider all samples as infectious. No recapping of needles. Earlier, we used to say dispose of needles after recapping. No, that's not the guideline. If at all you have to do, this is the right way. Or use needle shredders. This needle shredder is available for 100 rupees only. It cuts the needle and the syringe is also broken. Of course, if we use auto disposable syringes, auto disposable syringes, auto destruct syringes, sharp should be passed in the kidney tray, not by hand from one person to another. And lastly, before we forget, eye shield, which has become now very common with the corona, this should also be used when a splash is anticipated to the eyes. Universal precaution to be followed. These are some of the safer needle devices which have got built-in safety, like they break on their own. All immunization program people use auto destruct syringes, and now Government of India has a target that by 2023, no syringe should be used which does not have capacity to destruct on its own. So it should be all auto destructible syringes. That was a little bit about protection. But as I said earlier, despite all protection, needle stick injury can happen. You are wearing gloves, still needle can pass through the glove. So it becomes a medical emergency. Again, re-emphasize, do not put your cut finger into mouth, wash with soap and water. Try to get help and post-exposure prophylaxis as soon as possible, preferably within 2 hours, but maybe if not possible, as soon as possible within 72 hours. Okay, because when I say 2 hours, the benefits of PEP go on decreasing as the time passes. So maximum benefit is at 2 hours, but after 72 hours, it has been seen that virus gets established itself, and PEP may not be really useful after 72 hours of needle stick injury. How PEP works? The rationale for providing post-exposure prophylaxis is basically that systematic infection leaves a brief period of window of opportunity during which these medication, which are antiretroviral medication, can modify the viral replication. So after needle stick injury, now the question is whether you require, every needle stick injury requires a post-exposure prophylaxis or not. Perhaps not, because needle stick injuries are so common, particularly in operation theaters, in emergency, that if healthcare workers start taking PEP for every needle stick injury, they may end up being on antiretroviral therapy without being HIV positive. So we have to see what is the risk of transmission, what is the risk of adverse effects. So we have to basically weigh both the options. So there is a protocol in which you basically see what is the exposure code, meaning thereby what is the severity of the exposure. If the exposure has happened to intact skin only, post-exposure prophylaxis is not required. Unless the skin is abraded, chapped, there is dermatitis, you don't require a post-exposure prophylaxis. If it is to mucous membrane or skin is compromised with a small volume of exposure, this is categorized as exposure code 1. But if it is large volume, this is categorized as exposure code 2. And if it is a needle stick injury going through and through, which is basically percutaneous exposure, it is exposure code 2 or 3 depending on the severity. Similarly, we assess the source from where the needle stick injury has occurred. It may not be possible every time. You may not know from where it has occurred, which patient is it occurred. It may be in the laboratory where large number of blood samples are there. So if we know the source is negative, which is very unlikely, PEP is not required. Most likely situation is that source is unknown. We categorize this as status code unknown. If a person is positive, if he's asymptomatic, CD4 count is high, if we know, then it is status code 1, otherwise it is status code 2. So we categorize patient into degree of severity of exposure, status of the patient, and then do a matching. So if you have got anything 3, exposure code 2 or 3, or with source code 1 or 2, we require a post-exposure prophylaxis. In status code unknown, suppose it is not known whether the person is positive or negative, which is the common scenario, we really see what is the prevalence. Suppose this is a person coming to ART center in STM School of Kolkata Medicine, or it is in a ART center anywhere. The chances are high that person will be positive. If it is a low prevalence state district which has got a prevalence of 0.04%, like in some states in northern India, the chances that he will be positive is less. So we have to see this, the prevalence in the population, risk categorization, and provide PEP. So what is the regimen? PEP is provided for 28 days. The regimen, which has recently been revised in 2020 by NACO last month, includes a combination of tenofovir, lamivudine, and dolutegravir. Earlier, this used to be efavirenz, but now with the availability of dolutegravir freely in the National AIDS Control Program, the tenofovir, lamivudine, dolutegravir, which comes in a single tablet, 3 drugs, is to be given once daily for 28 days. Suppose dolutegravir is not available, it's a new drug, then the previous recommendation was to use tenofovir, lamivudine, lopinavir, ritonavir. The problem with this is tenofovir, lopinavir, lamivudine come in 1 tablet daily, but lopinavir, ritonavir you have to take 2 tablets twice daily, meaning thereby 6 tablets, 5 tablets daily, which sometimes has got issues of compliance. This is when we know that the person is not on ART. There could be a situation the person is already on this ART regimen. Then we have to really seek expert opinion whether the healthcare person requires same regimen or different regimen. We need to follow the person with a baseline antibody test and then do antibodies 6 weeks, 12 weeks, and 24 weeks. If a person is not seroconverted within 6 months, it is unlikely that he will convert. Tolerability, we have seen patients having a lot of side effects, healthcare person, like nausea, fatigue, headache. But these were seen more when zidovudine was used. Zidovudine causes loss of nausea, lot of fatigue, vomiting, diarrhea. These side effects are very low with tenofovir. Again, some of the side effects which happen due to efavirenz like vivid dreams, nightmares are not seen with dolutegravir. So this regimen which is now being provided, tenofovir, lamivudine, dolutegravir for 28 days has negligible side effects. Even the renal side effects of tenofovir do not happen in 28 days. Dolutegravir weight gain happens in 3 to 6 months. So 28 days of TLD, what we call as tenofovir, lamivudine, dolutegravir is quite safe. Moving a little bit away now from HIV to hepatitis B, it is recommended that all healthcare providers should be vaccinated against hepatitis B. Now, Government of India 3 months back brought out a circular to all the states that all healthcare workers in public health facility will be provided free vaccination for hepatitis B, which will be 3 doses, initial dose 1 month and 6 months. 99% of healthcare providers will seroconvert after this. But again, the guidelines recommend that you should do a anti-HBs titer, and if it is more than 10, it's okay. If it is less than 10, they should get a second course of vaccination. But the problem is anti-HBs titer is not freely available in government settings. So, but the comfort is that 99% of people will get seroconverted to after 3 doses. Now, if an industry injury has occurred, person has not been vaccinated, we should give complete hepatitis B vaccination series. If person is vaccinated, but we don't know what is the status of titer of antibodies, give a booster. If a person was vaccinated more than 5 years ago, give hepatitis B vaccine booster. Again, it is very important if we can do anti-HBs titer, anti-surface antigen titer. I will just give you the latest CDC guideline on hepatitis B, PEP. Persons who are vaccinated, who have got more than 10 international unit per ml of anti-HBs titer, nothing is required. If the titer is less than 10, basically then it is important that source patient should be tested. And if source person is antigen, surface antigen positive, give immunoglobulin. If he's negative, we don't require anything, neither immunoglobulin nor vaccination. Similarly, those healthcare provider who have been vaccinated, but we don't know their titer, they should be tested. Both the healthcare provider and the source should be tested. If healthcare provider has got less than 10 international unit of titer and antibody from the source is antigen positive, they should get immunoglobulin 1 dose and then repeated second dose after 1 month. Last scenario, if healthcare provider has a titer of less than 10 and source patient is surface antigen negative, they just require basically a booster dose, checking of titers again, and if titers are still less than 10, give 2 more doses but don't require immunoglobulin. Coming to hepatitis C, presently there is no post-exposure prophylaxis for C. There is no evidence to suggest that any interferon-based or direct acting antiviral drugs given at this time will be more effective. Only when they have a chronic disease, we need to treat them. Providing any post-exposure prophylaxis of hepatitis C is not recommended currently. So recommendation, when we say these drugs should be made available within 2 hours, it is very important that healthcare hospitals should make available to their workers written protocols. There are nice posters made by NACO. We should be actually displayed at different places in the hospital. There should be written protocol, whom to report, who will evaluate. They require some counseling and require drugs. Clinicians who are responsible for providing care should be available all 24 hours. And what has been adopted in most of the hospitals where ART center is there in public sector, that they provide 1 dose of antiretroviral drugs in the casualty, which can be provided by casualty medical officer pending evaluation, because evaluating clinician may not be available all the time. So to conclude, the HIV transmission to healthcare provider remains a minimum possibility. It is important to follow universal precautions. It is also important that all samples or all patients are treated as potentially infectious, and universal precautions should be followed. Diligently implement the post-exposure prophylaxis plan, sensitize healthcare workers, promote hepatitis B vaccination for all cadre of healthcare providers. Still, prevention remains primary. It is always better than cure. Thank you very much for your attention.
Thank you very much, Dr. Oriori, for your excellent presentation. And you made so simple a difficult subject when there is some controversy in treatment, particularly hepatitis C and everything. So we leave to the
Sir,
discussion to some
I have one
questions.
question, sir.
Yeah.
This is Shayo.
Hello, sir.
Yeah. May I ask, sir?
Yes, carry on.
Yes, sir. There was in your slide, I just saw that if the status of the patient is HIV negative, then we should not go for any further PIP. There's a post-exposure prophylaxis. But sir, what if the test was done in the window period when the patient can be negative, false negative? So what about that one, sir?
You have a very good question. If a person's status is known as HIV negative, generally he will not be in window period. When I say very few people will know their status, if they are coming to a particular facility, you have done HIV, still yes, there will be chances. So if exposure code is 2 or 3, you can still consider giving basically a post-exposure prophylaxis depending on the prevalence and likelihood in that area. You know, in such situation where it is negative or unknown, basically you have to look into into like if I go to a state in southern India, Tamil Nadu, Karnataka, Maharashtra, I would prefer to give rather than give it in UP or Bihar where the prevalence is low. But again, within the state also prevalence may vary between the district. You know, in country there are 6 high prevalent state, but out of 600 district there are 195 districts which are in category A and B, which means high. So it will vary a lot on that. And that is the situation we many times face, particularly when the status is unknown. You cannot test a person without his consent. Test will take time. So we prefer that you give one dose and then evaluate. Just give one dose of tenofovir, lamivudine, dolutegravir. That is the practice in most hospitals now, that they keep it in casualty. Because somebody coming at 12 in the night, you won't
Exactly.
contact the infection control officer. Okay, give
Mhm.
one dose, you evaluate in the morning. We try to get the result of the source also at that time, by that time.
And so one more thing is that which test is the will give you the earliest results of HIV positivity? Which test, sir? Is it DNA? DNA?
We are doing now fourth
PCR?
generation test. Fourth generation test is basically a combination of antigen test and antibody test. Naturally, antibodies will take a variable period of 3 weeks to 3 months to form, and it will be DNA. It will be the PCR which will come positive, but that again takes 7 days. Some of the kits say that it might come in 3 to 5 days, but no test gives you accurate result before 7 days. Again, the positivity of the DNA or RNA PCR is also not very high. So it is better to give prophylaxis, do a baseline antibody test, do a DNA PCR, I'll say fourth generation test at 7 day, but again confirm with antibody test at 6 weeks and 12 weeks.
Okay, sir. Thank you. Thank you so much.
Dr. Riwari,
Dr.
can
Sinha,
I
would
say to
you
you?
like to ask a question? Dr. Sinha,
Sorry.
can I ask a question?
Yes, carry on.
Yeah, Dr. Wari, this is Dr. Deepika Kedia. We see a lot of patients in the hospital who are especially nurses who work in private hospital who become hepatitis B or C positive while looking after patients, and they've not been vaccinated. So what happens to them? They're very scared to let the management know because they think they'll lose their job. We treat them, but what is the status on this? If somebody becomes positive and they've not been vaccinated by the hospital authorities, what happens to the job? I mean, will if they are hepatitis B or C positive, will they lose the job?
You know, as per regulation, they cannot be turned out of their job, even when it is HIV acquired during occupational exposure. But there is a lot of issues around this, because when many hospitals are doing pre-employment hepatitis B screening and they are positive and they deny them employment on one another count. So we have been working with government that there should be a hepatitis B legislation also, just like HIV the Act has come, that you cannot deny a person a job on basis of or discriminate on basis of HIV status. But there is no such guideline for hepatitis B as such. But again, it is the responsibility of the hospital to provide hepatitis B vaccination. I know private hospitals have got different rules than public sector, but ideally they cannot deny, and this can be actually taken up in the court if required.
Okay, thank you.
Dr. Gowdy, can I ask you, please?
Yes, please.
You remember in the context of HIV infections, you categorize the exposure source and the
Status
resource
code.
source.
Yeah.
Now, if we see patients say get 2 out of 3, and patient has got the CD4 count above 400, would you say that this group of patients will be okay without the antiretroviral therapy, or they should be on this treatment?
Dr. Sinha, there was an earlier guideline that such patients should be provided 2-drug regimen, and those with low CD4 count or high viral load should be provided 3-drug regimen. But that concept has now been taken away because it is said that the 2-drug regimen may not be as effective. If you have to give, you decide to give 3 drugs. And the newer drugs at that time concept were zidovudine, stavudine, those were the drugs available. So now with dolutegravir, which brings down viral load significantly within a very short time. So it will be very good to give 3 drugs and not go for 2 drugs, even when the CD4 count is higher, means exposure code is just 2. So
Other one,
benefit of doubt should go to the healthcare provider because the toxicity is minimal.
another thing in the context of hepatitis C infections. Now, why is it that we are not pursuing the course of directly acting drug for the prophylaxis when FDP, I remember they agreed to continue the drug with some trials, but it is conceivable because this virus, before it enters into hepatocyte, you can prevent it. So damage will be done almost nil. But if you don't do it, so there will be significant damage causing the significant complicated problems like chronic hepatitis cirrhosis and hepatocellular carcinoma. Having said that, the probability is still low because incidence is only 0.3%, that is about 3%.
1.8%, 1.8% for
Okay, so why
hepatitis
can't
C.
we use that one?
Yeah.
So,
So you have a good point. Basically, first thing is that hepatitis C virus in 25 to 30% patients gets cleared on its own. That is one. But race, there are 70% in which it doesn't get cleared. But there is a recommendation that such patient who have got exposure to hepatitis C person and needle stick injury should be followed up closely, because this chronicity will take almost 20 years to go to a stage of cirrhosis or a stage of hepatocellular carcinoma. And these drugs, direct acting antiviral drugs, sofosbuvir, velpatasvir, has become available now for last 4-5 years. And these PEP guidelines have not been revised. Earlier guidelines were ribavirin, interferon. Giving a interferon and ribavirin for post-exposure prophylaxis will lead to more problems rather than solving the problem. I agree with you now. With these cheaper, effective drugs being available, there should be a relook at that. I totally agree with you on that.
thank you very much. Have you got any more questions? Okay. So if I don't have any questions, I should conclude this session. And thank you, Dr. Rivari, for your wonderful presentation. And I must say, you made so simple with these very complicated clinical problems in our day-to-day course. And thank you very much for the wonderful talk. Thank you very much.
Thank you, Dr. Sinha. And I have a request to the organizers. I will share the PDF version of these slides. Please circulate it to every member. And because these are for information and all participants, I request you should share it widely to your friends, healthcare providers, so that they are aware about the latest updates. Thank you very much.
And thank you, Dr. Rivari, for being so kind to share the slides with us. And thank you, Dr. Amal Sinha, for to conduct the interaction very well. And I think it was an excellent talk right from the expert. Okay, so thank you very much once again. And we move to the next and the final session for today. Debashish, the next one. So we now have a topic on gastroenterology. It's an update on H. pylori. And the chairperson is Dr. Deepika Kedia. She is very well known to us in the Indian chapter. And the speaker is Dr. Subhashachi Ray. And the session is sponsored by Waterley. Dr. Deepika Kedia is a consultant gastroenterologist and liver specialist at EMRI hospitals in Dhakoria and Mukundapur, and she has her own gastroenterology clinic, and she's certified liver transplant physician and also an examiner of the MRCPI. So over to Dr. Deepika Kedia, and thank you very much for opting at the last moment to chair this session.
Thank
Dr.
you.
Deepika Kedia, please.
Thank you, Monodidda. Dr. Shobashachi Ray is our next speaker, and I think all of us know him because he's been the chairperson of the Indian chapter from the time it has been incepted in India. He's a consultant gastroenterologist and hepatologist attached to Police Hospital and BK Roy Research Center, and he has his own clinic called Remedy Clinic in Lake Town. He has been facilitated by the Peerless Hospital for dedicated service in June 2018 at the Silver Jubilee celebration. And formerly, he was also a visiting professor in gastroenterology at CMS Nepal. He's been, as I told you, the Indian chapter chairman and regional advisor for the Royal College of Physicians of Ireland since 2005, and has been the examiner and convener of the exams, clinical exams from 2006. He's also the president of the Remedy Clinic Study Group, which is located at Lake Town at his chamber. He has published papers in national and international journals and chaired many, many meetings, and teaches undergraduate and postgraduate students in medicine and gastroenterology. And his area of interest is chronic dyspepsia, H. pylori, and GARD. And now over to Dr. Ray for his talk on update on hepatology, on H. pylori.
Okay, can you hear me now?
Yes, we can hear you, Dr. Ray.
Yeah, good afternoon. Thank you for your kind introduction. Today, I'm going to give you a overview of this subject with particular emphasis on management and diagnosis from the clinician's perspective. Questions are being asked from some corners. Is H. pylori still relevant? Do you need to test and treat? I sincerely hope at the end of my talk, I'll be able to answer those questions. Now, before I start the actual talk, may I have a few minutes from you to say a few things regarding the origin, that is the recording the 70s, when he noticed the surge of medical progress in science and also the inventions in all spheres of medicine, including gastroenterology. And notably, the most important landmark was cimetidine, with 1977 launched in England, which followed the proton pump inhibitors and Helicobacter pylori in 1982. And I'm fascinated by this story of the invention of this particular organism, and cannot help sharing with you. So bear with me for a few minutes, and it's very interesting. And let's have the first slide on that. Historical perspective of the Helicobacter pylori. Although we are having this benefit now, it started as far back in 1875 when some physician from Germany isolated a spiral organism. There has been sporadic work since then in various parts of Europe, but no substantial work was done until 70s. In 1979, to be precise, everything started happening. I will give you the story at this point, which starts that young gastroenterologist senior registrar, Dr. Barry Marshall, went to his consultant and told him, can I have some material for research and publication, please? And his boss gave him a pile of notes and told him, look into that and find your material. So went back, went through these papers and found patients with upper GI symptoms of peptic ulcer disease coming, having endoscope, and then having the diagnosis of peptic ulcer or chronic gastritis. And then Campylobacter Campylobacter was not then at this time. So he is having cimetidine, which is newly available drug, and getting better, only to recur after stopping the treatment few months later and going through the same protocol again. So he went back to his consultant and asked him, what is this all about? And he said, I do not know, but please see Dr. Warren in pathology department, who knows all about it. He has found some bug in the gastric biopsy of the gastritis patient and peptic ulcer disease. So we went to Barry Marshall went to Robin Warren, and they started working together. And together they worked hard to isolate the bacteria in the lab, but failed to do so. They're very frustrated until the 1982 Easter weekend, when the penny dropped. It was a Friday, very busy day in the hospital. The lab was very busy with the routine work. So unintentionally, they left the petri dish inside the incubator and went home. When they came back on Tuesday, after 5 days, they noticed the bacterial colony grew and they were ecstatic. And then they concluded that most stomach ulcers and gastritis was caused by the infection of this bacterium. But it doesn't stop there. When he tried to present to the medical fraternity, there were lots of skepticism. They didn't believe it. How can this? So he decided to drink a solution of bacteria containing this bacteria and became ill. And he started having vomiting, abdominal pain. After 10 days, he had endoscopy, had noticed have a gastritis. The biopsy showed Campylobacter pyloritis. At that time, that's the name. Given antibiotic and it subsided. That's how he proved that bacteria was cause of the gastritis and antibiotic was effective. But there was a lot of work went on since then. And later on, in 1989, they decided that it's not a genus Campylobacter because the helical shape, the name Helicobacter was given. And it was announced in the World Congress and a Working Party report in 1990. And as you know, after so many years, in 2005, Warren and Marshall was awarded Nobel Prize for Medicine. And this is Barry Marshall, and this is Robin Warren. And I'm not one of those persons who fancy taking photographs with lots of celebrities, let alone a laureate. But when I met him in 2008 in New Delhi, I couldn't help myself taking a photograph with him, and I was very happy. Now that's the history part, but then comes the actual talk. This is whole started in 1990. The World Congress had lots of working parties, and this is one of them. And I was fortunate to attend this World Congress. And this working party, led by Professor Gino Tidgat of Holland, they together gave a lot. They looked at the epidemiology, pathogenesis, the clinical diagnosis, diagnostic methods, and treatment mode, and they recommended as those treatment. And I think those recommendations by and large still followed. Of course, some modification in coming days, but that has been followed since then. Now, next is the prevalence. How does the disease prevalent in this world? If you look at this map, you'll find India in blue, that means around 80 to 90% in 2008. And USA is about 20 to 30%. Now, 10 years later, this changed a little bit. That is, India is below 70% and the United States again further changed. So due to the diagnosis, treatment, and of course preventive aspect, there has been change for the better. So we have, but we still have a long way to go. Now, what are the a few facts about H. pylori? How this is the virus, so this is the bacteria, this is gram-negative bacteria with a flagella, the double membrane, with circular chromosomes. And what are the characteristics? The gram-negative microaerophilic bacteria, that means it can live within a low oxygen level, inhabits in submucosa of stomach and duodenum, and anchors in the submucosa underneath with these flagellae. They produce enzymes, mainly urease, that causes chronic low-grade inflammation, which leads to gastritis and ulcer. And the survival of H. pylori in the acidic stomach is dependent on the urease, which generates ammonia, leading to alkaline environment around the organism. Now, it's a route of transmission is fecal oral, oral, and via endoscopy, I'm afraid. And I think, unfortunately, in a lot of places, it's not properly disinfected, as you know. There's a lot to be improved. Is it contagious? It's more probably is, because it's found more common in the family members. Poor hygiene, sanitary conditions, and socioeconomic conditions are more important than racial factors. Infection may be acquired at any time from childhood to increased age. The earlier you inherit the infection, more difficult it would be to control unless you intervene. And cancer risk, International Agency for Cancer Research, WHO, has listed as carcinogen class 1. And genotypes, there are many genotypes and strains. CAG-A and VAC-A are induce inflammation, but CAG-A is more virulent. Clinical presentation, how do that present? Patient may come, they're asymptomatic, who may find H. pylori infection in course of investigating, particularly endoscopy. They're doing some other reasons. Patient may come with the features of chronic dyspepsia, gastritis, duodenitis, and together with peptic ulcer disease, gastric ulcer, duodenal ulcer, which consists about 20%, rest is non-ulcer disease. Complications such as gastric adenocarcinoma up to 2%, gastric lymphoma, mucin-associated lymphoid tissue lymphoma, and this is more common, not very rarely non-Hodgkin's lymphoma. The diagnosis. How do we diagnose? Non-invasive, that is carbon urea breath test. This is supposed to be a gold standard worldwide. And how do you do it? Patient drinks C14 level urea. It's metabolized in the inside, and then level carbon dioxide is detected in the breath. But unfortunately, it's not so easily accessible in this country. Blood antibody tests, stool antigen tests, and now PCR is also available, but they're not commonly used in Indian setting, particularly in our practice, for various reasons, particularly both. And it may be useful for community screening or post-treatment follow-up. Invasive endoscopy. That's the mostly practiced investigations. Rapid urease test, RUT, is very commonly practiced. Histology and culture. Histology is very good provided you have a lab with a histopathologist who is experienced and interested in it, and it takes time, up to 7 days, and all this put together. Initially in the early 90s it was very more common, but nowadays I think, at least in India, it is very not commonly used in practical setting. Culture has a problem. Even it needs a proper set up in the lab, and it yield is not that good, about 30-40%, even in the best places as far as I know. So it's urease test we bank on mostly. And what is the principal urease test? It's very simple. The urea with presence of water and It is it is reacted in presence of urease, broken down to carbon dioxide, water, and ammonia. And what it happens actually, this ammonia is important, alkalizes the medium, and the pH shifts to be detected in the color change of the phenol red inside the medium of the kit from yellow at 6.8 pH to magenta 8.1. And of course, usually if there's lots of bacteria, it take it from the antrum, then it comes to be positive within a short time, but it directly depends inversely proportional to the number of bacteria. If there is more bacteria in that particular patient who are they takes then it's quicker. And some patients who are nowadays often treated with PPI as well as the antibiotics, it can be delayed to up to 24 hours. So before declaring, the negative one should wait. If it's positive, it's fine, but negative should be delayed. We usually declare next day when the patient comes in the clinic. Now, how do we do the urease test? Simple. We take biopsies from the endoscopy, put it from the antrum, and put it in this slide. And then if positive, it becomes red. If magenta, it is negative, remains zero. There are many kits available in India. And of course, initially started as a flow test from the Perth, Australia, hosted by Barry Marshall, but now an indigenous kit is available in all countries. So it's easily accessible, simple, convenient, and it can be done on the endoscopy room, and they claim accuracy around of sensitivity and that is about 90%. Treatment. What sort of options are left? Antibiotics. The antibiotics was advocated in 1990. We still carry on, only the type of antibiotic may have changed. Then proton pump inhibitors also was advocated in 1990s. Still we are having antibiotic, the proton pump inhibitors. They are working the same pattern. You can use either of them. Nitroimidazole, metronidazole, tinidazole, oridazole, etc. But we have a but in it, which we can discuss later on. And bismuth. There are two types of salts available in the world: CBS, colloidal bismuth subcitrate, and bismuth subsulcidate. In this country, there was a BSS available earlier on, but there was a period when nothing was available. Now CBS is available. And then probiotics is very helpful. Come to that in a minute in the next slide. And rifabutin has been mentioned for, I didn't think you need to use that, but it's just mentioned for the completion sake in a very resistant situation. It's an anti-tuberculosis drug, but it's not used very, I haven't used it actually myself. And vaccine, even after a decade of trial, I think it hasn't crossed the barrier of, as far as I know, the phase 1 trial to succeed. Therefore, it's not under consideration for the patient's prevention at all. Precautions, probiotics. Probiotics is helpful, particularly containing lactobacillus acidophilus and bifidobacterium. It improves 2 ways. It helps to eradicate H. pylori and prevents the side effects, particularly from the antibiotic. Bismuth, metronidazole, tetracycline, and probiotics. There are certain rules which sometimes we do not follow, but it should be given in empty stomach before 1 hour or after 2 hours. And fortified drink containing calcium should be avoided. Doxycycline, which is something I use nowadays more often, and avoid taking with any antibiotics with iron supplement, no iron supplement, multivitamin, calcium supplements, and other laxatives. So, eradication treatment. Monotherapy was tried in during the and was said no during the 1990 World Congress, no recommendation. Dual therapy was also tried, very low success, therefore it has been negated. Now the triple therapy was recommended, whatever may be the ingredients of the triple therapy. The triple therapy has been invoked, but now more often than not, triple therapy is used and been more useful. I'll come to that later on during the course of my talk. And sequential therapy has been used by some. That means by dual therapy followed by a triple therapy. and I haven't needed to use them. Now, publication recommended that many publications in India as well as abroad, innumerable publications, when there was a real surge of interest during 90s. Now it's settled down a bit, but I just wanted to quote a few to give you some idea. Now, this is a very important landmark publication from the European Helicobacter Microbiota Study Group, where 43 experts from 24 countries examined on indications, associations, diagnosis and treatment, and prevention, and H. pylori gastric microbiota. I wouldn't like to go into details for the shortage of time, but I think when we discuss and summarize, we can give some of these points and bring back the slides if we need to know further. ISD Task Force guidelines for H. pylori in 2018. They echo the same thing, like if it's transmissible, regional variation has been noticed by the task force, and all patients, they recommend all patients with PUD, gastric ulcer, multiple lymphoma should be treated for H. pylori and treated accordingly. H. pylori eradication does not cause GERD, unlike some people's thoughts. And there has been some sort of suggestion, particularly in 2002 World Congress, which I attended, that the H. pylori troubles up the fundus and causes more problem, and then therefore end up with some of these patients having the GERD. But I don't think it is true now. As far as I know, it's been nullified by the subsequent workers. And testing and treatment of H. pylori is indicated in patients with long-term NSAID users. Now, there's been many publications. There's one publication at the beginning by Deepak Bhasin, which is looking at the triple therapy and its benefits. And then there's a major publication is from Tyagarajan and his team, which is a multi-central trial, the study on geographical difference in antimicrobial resistance pattern of Helicobacter pylori clinical isolates from Indian study, which is involving Chandigarh, Delhi, Lucknow, Hyderabad, and as well as Chennai. And they said, in Indian population, the prevalence of resistance of H. pylori is very high to metronidazole and moderate to clarithromycin, amoxicillin, and low to ciprofloxacin tetracycline. And the subsequent slides, as you can see, the leader, Tyagarajan et al., perhaps is the main person contributors, although it's not mentioned here. India is scoring high with 80% metronidazole and amoxicillin and clarithromycin, the modest one, resistance. Looking at the Indian scenario, again, Tyagarajan is the male player. He actually has maximum number of patients studied, and the same sort of figure, 78, 45, and 33. Now, this is all about the studies. I will not go in details, but a few words on bismuth compounds, which has been around for more than 200 years, has been used for medicinal purposes, and now it has been used since, particularly in 1990 World Congress recommendation, and is being used quite regularly all over the world. And in the West, I think you'll find a solution called bismopeptide is available in the solution form, but here we have tablets. It inhibits H. pylori urease by blocking the active sites, and also interfere with the addition of the H. pylori, and therefore prevents its action, and partially involve the prostaglandin mechanism, thereby acts as a cytoprotective agent. And in the recommended dose, usually 120 milligram tablet 4 times before meal, but more conveniently that I normally use is 2 tablets, that's 200 twice daily, for total 480 milligram daily. The concomitant use of antacids and milk should be avoided within 30 minutes. Quadruple therapy, which with CBS, they considered to be used in increased efficiency, and recommended is first line management. And achieve superior eradication with safety and tolerability comparable to those obtained in standard triple therapy. And now, in my experience, as I put in a few slides, that what I found is a few examples. One 30-year-old gentleman with not a very regular life and on food habits has been on PPI and not getting better, came for endoscopy, found just a mild enteral gastritis, and was treated with quadruple therapy and remained well and in subsequent follow-ups. And this is a 44-year-old lady with rheumatoid arthritis on NSAIDs and PPI. And this goes to show that a PPI in itself doesn't always stop having the erosions. This patient also had H. pylori positive and had quadruple therapy and better. This is the patient, a farmer and 55-year-old from village, never had any medicine, came with GI bleed. They found a large ulcer and bleeding, and my usual treatment of resuscitation and PPI, patient was given quadruple therapy and is improved. The last one is the patient with chronic iron deficiency anemia who came to our clinic, and it was in the PLS hospital actually, and was found to have clot in and raised elevated area. There's a tumor which is found to be malt lymphoma, and was given the quadruple therapy along with a prolonged period of PPI, high dosage, and the patient became normal afterwards. So my preference in the clinic would be to nowadays to give quadruple therapy. With antibiotic, I would like to give now, prefer to give doxycycline, and sometimes, of course, ciprofloxacin or levofloxacin if doxycycline is not suitable. Any of these PPI would be fine. CBS, two tablets, 120 milligrams twice daily, and probiotics, of course, and that's how it goes for at least 10 to 14 days. There has been many regimes, but at least should be given for 7 days. I do not use nitronitazole nowadays at all, unless it's necessary. Helicobacter kit was in the market, and there is a surge of in use where everybody started putting on patients with any dyspepsia of H. pylori kit. I certainly don't use it even in a proper patient for 2 reasons. First, that if the patient has a problem with any of these ingredients like antibiotic or any other problem, nitronitazole in it, then you cannot separate it, they have to throw the medicine. Secondly, more importantly, that for that reason, I do not use any combination if I can help it, that you tend to forget the content in it. Therefore, I use it separately, and most people actually follow, although it may cost a little more, but at the end, it's beneficial to the patients. Now, in my clinic, there's been an experience over the last 24 hours, 12 months. Of course, this is excluding the lockdown period, and there has been 54% of RUT positive. CVS was given in 35 patients, and cytoprotection on 31 patients. And I think this is it's a trend. It's not a proper data that I can quote you, just to give an example and that how things are happening in a peripheral clinic like ours. And the audit shows there hasn't been much change in the incidence, at 22.7% in 2014 and same pattern 2019. That thing, bearing in mind that we in the urban area deal with mostly urban patients and suburban patients whose hygiene and social economic condition is quite reasonable. Therefore, it's not reflected so much in our data. Perhaps the Tyagarajan's cases, they have data from the villages as well as in town. Therefore, it may have a different impact on the data. Now, the take-home message is worldwide prevalence more in developing countries. The H. pylori gastritis has to be excluded before reliable diagnosis and functional dyspepsia can be made. Eradication heals gastritis in long-term PPI users, and it also stays longer if those patients are still on PPI. It's a first-line treatment for the malt lymphoma, as I mentioned earlier on. Urease breath test is the best recommended non-invasive test, but unfortunately, It's not easily available. I've been trying to get this in the last 1 year for those follow-up patients, particularly. There are 3 or 4 centers who has been offering. There's lots of hurdles, and more so in the last 6 months in lockdown period, they're not functioning. Quite expensive, difficult to get, and there was a time consuming. Therefore, it's not been used so much, except one patient so far. Now, when there is an indication of endoscopy, there's no contraindication for biopsy. A rapid urease test is recommended as a first-line diagnostic test. Bismuth is safe, effective, has no side effects or resistance, and should be included in triple or quadruple therapy. Quadruple therapy regime containing bismuth have increased efficacy and recommended for the first-line treatment and achieves superior eradication, safety, and tolerability comparable to those obtained in standard triple therapy. It's quite effective as cytoprotective agent too. Thank you for your kind attention.
Thank you, Dr. Ray, for your wonderful talk and very comprehensive talk. Is there anybody who would like to ask a question? Is there anybody who would like to ask a question? Nobody? So can I just ask the first question, Dr. Ray? What are you recommending patients to stop taking PPIs before they come for endoscopy? Because that is traditionally what we do. And how many days are you recommending that?
No, ideally it should be stopped for 2 weeks, but unfortunately in this country is very difficult to follow. And at the end, as an end user, it is recommended by all bodies, the ones that I said, the European data and everywhere, it should be stopped at least 2 weeks before. But in practice, we have to forego that. But it should be done. I fully agree with you.
Dr. Chattopadhyay has a question to ask. Please go ahead, Dr. Chattopadhyay. Dr. Gopal Chattopadhyay. He's asking, do we follow up tests on patients who have been treated? Do we do follow up tests?
Yes, we do follow up tests. I think the majority of patients do agree for a repeat endoscopy because that's not ideal, of course. But this breath test comes into being, but patient, because of difficulties, the patient do agree for a second test, and I have done in many of them. But those who disagree, we think we should follow with this breath test. That's what I'm planning for the last 1 year. And I think that's the plan now. But it should be done, and usually done 1 month after the actual treatment is complete, between 1 or 2 months, ideally.
And Dr. Ray, since nobody else is asking a question, I would like to know.
Yeah, I've just got one question.
Okay.
Just one question. I'm sorry I joined a bit late because of other commitments. This is a question for Dr. Ray, because it was only his lecture that I could listen to. Is there any sort of a correlation between an H. pylori infection and the development of any future gastric malignancy?
Yes, there is, definitely. As I mentioned in my slides, there is of course, that malignancy means carcinoma and a lymphoma. And there is about 2% chances of having adenocarcinoma. Of course, if you leave a treatment, the H. pylori infection untreated and unabated, then definitely it can raise the possibility of having a kind of cancer. But
what about carcinoid tumors?
Carcinoid, I'm not aware of.
No, we've not seen any carcinoid associated with H. pylori.
No, the reason why I asked this question, because around 10, 15 years ago, there was this theory that long-term PPI can actually lead to a development of a carcinoid tumor. So I was just wondering whether it has got anything to do with an H. pylori or coexistent H. pylori. So
you may be right in that way, but what happens in this country, which I haven't mentioned, but it's so common, is like a gas medicine in this country, and everybody is taking from the corner shop, and they are taking without asking you and me. And I'm not sure what's going on. Perhaps there is a truth in it. We didn't assess that, but this gas medicine has been indiscriminately used. Now I'm very sorry to see such a novel invention of PPI has been used so indiscriminately as a gas medicine. But what is the consequence? There are some some consequence. That I think Dr. Professor Gaur Chaudhary had a write-up on this. We may have a look at it with the complication of PPI, but I'm not aware he mentioned about carcinoid. Do you, Deepika?
I have not seen a single carcinoid, Dr. Ray, myself.
But have you read Gaur Chaudhary's write-up?
No, I have not read it, but I have not seen a single carcinoid patient.
But anyway, complications. People are so hooked on to this PPI that they don't see. But of course, we should try and reduce and stop if we can. But I'm not sure about carcinoid.
Okay, Shorbani is asking any role of prophylaxis for recurrent infection, Dr. Ray?
I think that there is no prophylaxis as such. It is a prevention. That means hygiene is the most important thing. Is, as you see, that one prevention the patient and the patient's household can do by washing hands. It is a fecal oral transmission. The other thing, which I'm not sure it can be done, the proper cleaning and disinfection of endoscope. My question is it been done? Who does it? I'm not sure. I try to do it, but I'm not sure whether it's done properly. It's taken just for, I'm not sure, but my fear is that it's not done properly in many situations.
Acha, Dr. Bhattacharya is asking treatment of H. pylori gastritis in pregnancy. How would you do it?
I don't think there is any special problem in pregnancy as such. The particular drug is available, is permitted by the obstetrician. I think antibiotics are given, PPIs are also given, so it should be. It can. Bismuth has no problem. Because one other thing I forgot about bismuth, which has no side effect. One thing we must remember, I didn't mention, that some of these patients may have a plaque stool, which is harmless. But apart from that, all these medications can be used without any problem, as far as I can see.
Can I just make a comment?
is asking, what is the percentage of recurrence of H. pylori infection?
Usually it varies, but generally 1% per year has been advocated by some experts.
Can I just come back to the incidence of carcinoid with H. pylori? I think it is a misnomer because PPI is a potent drug for increased level of gastrin level and also chromogranin A. So they are falsely elevated. That's probably a hint when you see a tumor in the stomach due to H. pylori and the chromogranin A and gastrin level goes up, that stage probably one suspects the possibility of neuroendocrine tumor. Otherwise, there is no relation between the H. pylori and the carcinous tumor.
Yes.
Olga, I've just posted a link in our WhatsApp group on this particular study. There has actually been a study on carcinoid, gastric carcinoids and increased use of PPI. I've just posted it so anybody can have a look at it.
PPI may be related, yes.
Yeah, that's what my question was, whether there is PPI linked to
not quite H. pylori per se.
Okay, yeah.
Okay, any other questions we have?
Pathy of the stomach, what is called the gastroparesis. The question here, if we can use domperidone to treat the gastroparesis, whether or not the incidence will come down. Have you got any idea about this?
I don't think I know about this, but I feel I understand it's an important proposition that you propose. We normally give the domperidone quite often for gastroparesis, of course, but the coincidence may be that when you treat the patient with a triple therapy or quadruple therapy, if the patient may be on domperidone, it might help. But I am not sure whether there is direct correlation in my practice as far as I can see. But it's an important point to note. We always learn. Maybe it's a point to note from the future, but I don't think that changes the incidence of the actual H. pylori prevalence or anything, as far as I know. You got to look it up.
But I don't know, there's some, lot of research has been done on the use of probiotics, lactobacillus especially. So I think in our country, like most of the people do drink, do have, yogurt with their food.
Yes.
So I think it probably has a protective effect.
Yes, certainly.
Any other questions do we have?
Okay.
So Since there are none, we can actually close this session.
Thank you very much. Very good talk.
Okay.
Dr.
So,
Mukhopadhyay, should we close this
yeah,
session?
yeah, you can.
So let's close this session. If anybody has any other further questions, they can, put it in the group, in the Royal College of Physicians Ireland group, and Dr. Ray can answer those questions. Thank you, Dr. Ray, for such a comprehensive talk. You've covered everything. And I remember meeting the two Nobel Prize winners in the meeting. And they were like celebrities because everybody was clicking pictures with them. Thank you very much.
Thank you, Dr. Deepika Kedia and Dr. Subhash Ray, for a very lively discussion and interaction. I just would like to mention we have two, sort of surprise artists or physicians who've joined. I don't know if Dr. Jeff Chadwick, are you still there? Jeff, would you like to say something before we conclude?
Yes, I'm still here.
Okay.
Oh, well.
Just to say,
Jeff, can you
if
make
I can
yourself
get the
visible?
video
You're still
working.
invisible.
Yes. So just to say, sorry, I've got my hand on the camera. Thank you very much to all the speakers and the chairs this morning. It's still quite early for me here, but it's very good to see all of my old friends. So thank you very much.
Thank you. Nice surprise, and glad for you. You had to get up 6 in the morning to attend this webinar, so that speaks a lot on your.
No problem.
Yeah,
that's
and
my
also,
grandchildren you can hear in the background.
Okay, thank you very much. And Dr. Gopal Chattopadhyay from Surrey has also joined in. He also woke up at 6 in the morning. We saw him. They said, Dr. Gopal, would you like to say a few words? And I think during the subsequent CMEs would like to defer the sessions maybe to the afternoon to accommodate speakers and chairpersons from UK or Ireland. Gopal, so are you there?
Nothing much. Thank you. Thank you so much. It's been a pleasure as usual. Thank you.
Okay. Thank you. So I would like to pass on this sort of mic to Dr. Sujoy Mojumdar to give the vote of thanks, and he managed to join in spite of all his commitments. Over to Dr. Sujoy Mojumdar.
Thank you, Dr. Mukhopadhyay. And first of all, my sincere apologies for joining in so late, because I was involved in another teaching session, and so I could join only after I finished that session. I'm feeling just like an Indian politician who is asked to inaugurate or conclude a scientific conference where he knows nothing about it, and he still manages to say a few words. And that's what I'm doing right now, because I have not attended this particular symposium for the large part of it. In fact, I could only attend the last few slides of Dr. Ray. But I'm pretty sure, going by the past experience, this has been a fantastic meeting. And my heartfelt thanks to all the speakers, Dr. Omar Mustafa, Dr. Bibi Rewari, and Dr. Sabyasachi Ray, as well as the chairpersons, Dr. Prakash Chandra, and Dr. Deepika Kedia, and Prakash Chandra Mondal, Dr. Deepika Kedia, and also
Amol Sena.
Oh, Dr. Amol Sena, yes, sorry. My apologies. So I'm pretty sure all of you have played a very important role here. And this series of lectures that we are having over the last 3 months, I'm pretty sure it has gone a large way in enriching our knowledge. We practice a sort of a very, in a tunnel vision way nowadays. We know everything, or try to know everything about our own specialities, but know very little outside it. And I'm pretty sure meetings like these will really tend to widen our knowledge and our field of knowledge in the field of the different branches of medicine. Lots of new developments are taking place, but we know very little about them. So I'm pretty sure I would really have everybody has enjoyed it, including all the faculties and also the delegates have enjoyed the discussions. And what I would suggest is that we should keep on having this sort of serial meetings in the future. And maybe we can record, or we should record all the presentations so they can be logged up into our Royal College Indian Chapter website. So this can serve as a sort of a lesson for everybody who wants to really recapitulate these things in the future. We should really be thankful to the sponsors, Waterley, who have played a big role in sponsoring this meeting at this time of the year, when a lot of the people are actually going on a holiday break. So with that, without wasting further words, I will draw this session to a conclusion today. And thanks everybody for being a part of it. Thank you very much.
Can you ask the organizers to stay back a few minutes to discuss about the next session? Hello, can we?
Yeah.
The next
Okay.
session would be the second Sunday of December. And I think as we are all here, I think they proposed, we proposed the topics, the respiratory, neurology, and either pediatrics or any other branch, third one. So any other options, or do you agree or disagree? And we have a few sort of persons focused to talk on those subjects. So Manojit can throw some light on this area.
Okay, Dr. Roy, I'm sorry to disappoint you. I'm sorry to disappoint you again, but again, next Sunday we have got the National Insulin Summit where I'm one of the faculties. So that's on Saturdays and Sundays. So I don't know when my time slot is going to be like.
That will be second Sundays of December.
Yeah, that's on 11th and 12th of December.
Oh, I see.
But anyway, I'll try to join in just like the way I've done today. Hopefully they'll send me a program within the next few weeks, and then I'll be in a position.
In December is 13. Second Sunday is 13 December.
Yeah, 13th. Yes, that's 13th. So Shuja, is it?
Sorry,
12th and
it's 12th and 13th. Sorry, 12th and 13th.
12th. Okay. Okay.
I think
It's 12th and 13th.
next Sunday, if you want to shift, there are lots of people are involved on 12th, 13th. 20th will be too close to Christmas, or it doesn't matter.
I think we okay with it on 20th. That is fine.
Anyway.
Okay.
So,
okay, I think we'll think about it.
I think let's have a meeting and then we can come to a conclusion. Let's go discuss it.
Post in the